I'm a consultant dermatologist, so I work on the NHS, but I also work privately as well. And acne is something I see and treat every day, obviously. But when I'm not treating acne-prone skin, I'm seeing people and potentially talking to them about skincare. And I need to know, I need to be aware of whether they've got an acne tendency and whether some of the products I'm recommending for them could actually make their skin worse. So even if you think, oh, I'm not someone who treats acne, you do come across it with the people you've seen. You do need to be mindful of what you're recommending for people. So I'm going to try and keep this talk industry neutral. I'll try very hard to do that. We do sell Neostrata products at the clinic, but we also sell other branded products at the clinic. And we take a slightly cherry-picking approach to what we stock. We look at what we think are good products, we look for the evidence, we get patient feedback, and if they pass those points, then we stock the products. So I'm briefly going to talk about the pathophysiology of acne and also the scope of acne treatments available. I know we've got a very mixed audience here from prescribers and non-prescribers, but I'm really going to hone in on the management of mild acne or acne-prone skin, which I think everyone here is probably seeing in their patients, and that's basically topical therapy. And then I'm also going to talk about alpha-hydroxy acids, polyhydroxy acids, and also the new product, N-acetylglucosamine, NAG. But you've had a lot of that this morning, so I'm really going to be talking about where we might use them rather than going back into the science of those molecules. So if we look at the prevalence of acne, is it increasing? Well, probably. Are we more concerned about it? Well, definitely. And we can see from this graph that it really is a first world problem, and we can see over the last 5 to 10 years that everyone's been more concerned about it. And I think the gradient on this line probably equates to the increase in the use of the mobile phone for selfies. So everyone's so obsessed with their skin, taking photos of their skin, and people are taking more selfies, they're more concerned about their skin. Last week I was in Australia at a conference and I learnt that the #1 item that was being stolen from Australian pharmacies was an over-the-counter acne preparation. So that's telling us a few things. That's telling us that our teenagers are very concerned about acne. They're potentially not getting treatment from where they need to, but they're also embarrassed. They're embarrassed to go up to the pharmacy to ask for the treatment, so it's easier to steal it. So I found that very interesting. So if we look at the pathophysiology, what causes acne? Well, there's 4 main components, and the first is increased sebum production, which relates to increased androgen levels, which relates to puberty. That then causes colonisation with the bacterium P. acnes, and then if that's combined with altered keratinization or desquamation of the keratinocytes in the duct of the pilosebaceous unit, we then get blockage of those pores, which leads to inflammation, and that gives us acne. Now, what you may not know about acne skin is there's also other differences with the skin of people who have acne and who don't. And this was a nice study that looked at teenage boys, and they compared boys who did have some acne and boys who at that stage didn't have acne, and there were some differences. And the main difference was the barrier function of the skin was poorer in patients who had acne, and there was also increased transepidermal water loss. So that's telling us that that barrier function's weaker, we're losing moisture through the skin there, which wasn't seen in the non-acne sufferers. And the other interesting thing was there was a seasonality to it as well. So the skin was actually worse in winter. There was more water loss in winter, the barrier function was worse in winter. So just park that thought. If we look at acne through the life cycle, everyone equates acne with the teenage years, and that's certainly the most common time that we see acne. It's almost 100%. 100% of teenagers at some point will have some degree of acne. The other thing that we are seeing more of is this magenta line there, which is actually a hormonal pattern of acne, which we see in women who might develop acne for the first time in the 20s or their 30s. They haven't really had much of a teenage problem with acne, and they're a slightly more difficult population to treat, but it's an increasing population. And then on this slide, we've also got 2 other conditions. So rosacea is the green line. It's not acne, it's a separate condition to acne, but it is sometimes called acne rosacea. So it's important to be able to recognise if someone comes in and you think they've actually got rosacea rather than acne, because our treatments would be slightly different. And then if an elderly patient develops with comedones for the first time in their 60s, think of other things. So it could be something called Favre Ricochet, which is usually due to sun damage, and it's a production of comedones due to that. So with treating acne, I divide it into mild, moderate and severe. I sort of try to keep it simple. And as a non-prescriber, these are the things that you've got available to you, and before people come to see you, they've probably already tried a number of things from the department store or the pharmacy. But you can see there's a broad range of things you can do, even if you're not a prescriber. Now, if you are a prescriber, that opens a few more doors, and that means you can probably start treating slightly more severe acne with prescribable products. And then in this country, as a dermatologist, I have the whole range of treatments available to me. So I do prescribe isotretinoin, and I think it works very well when it's indicated. Now, if we see scarring, we need to push everything to the left there. So if I've got a patient who's got mild acne with scarring, I want to be treating them more aggressively, because the easiest way to treat acne scarring is to prevent it. So I think the purpose of this slide is to know where your boundaries are, know what you can and can't do, and recognise if something's more severe than what you can help with, and then know when and who to refer to. And your patients will thank you for getting a positive outcome rather than coming back and saying, oh, it's not working, what more can I do? So I think it's really important to recognise when it's time to refer on. So if we look at the emerging trends in acne, well, there's certainly a move away from topical antibiotics, and we're certainly using oral antibiotics in shorter courses, and this is all because we're concerned about bacterial resistance. So this is a worldwide trend that's going on. Certainly we're now paying more attention to adherence. Are the patients actually doing what we're asking? And this relates and correlates completely to tolerability. So if a product isn't nice to use, people don't use it. Patients are becoming better educated about acne treatments, and this is partly due to the internet, but they're also becoming more concerned about the total appearance of their skin. So once we clear the acne, it's questions like we've just heard: how can I improve pigmentation or tone and texture of the skin? So people are definitely asking that. We're also seeing an increased use in mineral-based makeup. And fortunately, as a dermatologist, our acne scarring treatments are improving. Our lasers are becoming more sophisticated, and there's more that we can do. And the other thing that's reasonably new is the emergence of at-home light-based devices, and we're yet to really know how well these work, but you've probably seen some advertising around on tube stations and different places about this new form of treatment. So when we have a patient who might have acne or might have an acne tendency, I mean, obviously it's important to sit down and talk to the patient, assess the patient, and listen to what their concerns are. Not what you think's going on, but what they say is the major concern for them. And then always ask them, what is the skin like or the acne like today? So acne is a variable thing that can fluctuate from day to day, week to week. So you might be seeing them on a good day. So always ask them, is this good or bad for you? The other thing to do is to find out what they're doing to their skin. And I'm sure everyone here knows that people do weird things to their skin. So putting toothpaste on lesions, scrubbing their acne away. So it's important to know what they're currently doing and what they're currently using. They might be using something which is far too occlusive as a moisturiser for their skin. And that might be driving their acne. That may be the whole problem. So once I've done that, I then determine the extent, severity and pattern of the acne and tailor a treatment regime for that patient. But the other important thing is I then look at what I think they're going to adhere to and what they're going to be capable of doing. And then I'll modify that treatment plan so it's something that is good for both of us. I know they're going to use. So if we now hone down onto acne-prone skin, mild acne, what are the topical agents we've got? Well, look at the list. It's quite exhaustive. And I've broken it down into the different mechanisms of action, and you can see that there's some products there that cross over a number of the columns. So they're probably the ones that are going to be very useful for treating acne or good for acne-prone skin. So what makes a good topical treatment? Well, it needs to be effective. It's got to work, otherwise we're not going to use it. It's got to be easy to use. It's got to be safe and well tolerated. It's also got to have a pleasing consistency and smell. So when a rep brings a new cream around, what's the first thing we do? We put it on the back of our hand, we rub it in, we smell it. And that's what patients do. So that's very important for topical treatment as well. And then finally, it's got to be affordable. But the main problem with the standard acne treatments or topical acne treatments is that they do irritate the skin. And whilst benzoyl peroxide can work well, it is reasonably irritating. And that's the major or number one problem that we have with that preparation. Salicylic acid, if in very high concentrations, can also be like that. In lower concentrations can work much better. But the whole point is, if we go back to that thought I asked you to park, if we've got skin that's not normal to start with, we've got a decreased barrier function, and we start putting irritating products on it, it's going to make it worse. And what we do know is that if something's irritating the skin, people don't use it. So the number of times people have told me, I used benzoyl peroxide for a week, it didn't work, it just made my skin red. Well, it's probably not going to work in a week, and there's other ways to use it to make sure they don't get the irritation. But the bottom line is they've stopped using it, and that's a treatment failure. So my algorithm for acne-prone skin or mild acne is to start with a medicated wash. And I think this is where the alpha hydroxy acids and the polyhydroxy acids really come into their own. So we're really using them as a wash, more as an exfoliant, because it's a short contact. You're putting it on and rinsing it off quickly. And I much prefer this to using a scrub at home, so I think it's much more sophisticated or a better process to be doing this chemically rather than physically. So using a medicated wash with one of the alpha polyhydroxy acids is a starting point. And it's also something that's simple for them to do. So most people wash their face with something. So instead of reaching for this bottle, they're reaching for that bottle. So if you've got a 15-year-old teenage boy who you know is not really going to do much with what you're telling them, that's something that's very easy for them to do. I also like to get people on a retinoid or retinol, and there's different options there, and it depends on the age of the patient, it depends on their skin type, whether they've got associated conditions like eczema. But first-line treatment for me is to get them on a retinol or a retinoid. And then the other important thing is to say, yes, you can use a moisturiser. A lot of acne patients have been told, no, you can't use a moisturiser, it'll block the pores. But it's important to be able to counteract any of the irritation that we might be causing, especially initially when we start a retinoid or a retinol. And with the retinoids and retinols, I tend to wean up. So I might say to a patient, start 3 nights a week. If you're tolerating that, go up to every second night, go up to every night. And at any point, if we get too much redness, dryness or irritation, because they are the main things that we're looking for, then we just take a night or 2 off, let it recover and start again. Some patients I do prescribe benzoyl peroxide for when the acne is worse. It can work very well. And occasionally now I'll prescribe topical antibiotics, but it's always in combination with something else. But as I've said, the trend's moving away from that. And then we can talk about the icing on the cake, which is the alpha hydroxy acids, polyhydroxy acids, and NAG. And using those either in office or at home, but also the use of in-office pills. And that's a really good way to be able to engage your patient. You can see them on a regular basis, you can see how their skin's progressing, and you can fine-tune your treatment with that. So that's a good tool. So now I'll just focus on the alpha hydroxy acids and the polyhydroxy acids. So as I've mentioned, we can use them in high concentration, and that's the in-office treatments. We can also use them in the home care products, and they work in a slightly different way in that respect. I know you've had a lot of science this morning, so I'm not going to go over all of that again, but when they're used at lower concentrations at home, we really are building up that barrier function. We're increasing the moisture in the dermis and creating a protective effect, and working more as an anti-inflammatory agent as well. So it can be beneficial as a standalone treatment for acne-prone skin, or with some of the other acne treatments that we use. Then I'm going to talk about N-acetylglucosamine, which is the new product, and how that can relate to our acne algorithm. So the benefits of these treatments are that they do cross a number of those columns and treat acne or acne-prone skin in different ways. And what does that relate to or mean to patients? Well, it means it improves their acne. They get decreased comedones and less inflammatory papules. but it also improves skin health. And Lorna spoke about skin health this morning and skin fitness. We use the term skin health a lot in the clinic, and it's something that I haven't really heard much from other people as well, so it's a novel concept. So not just saying you've got acne, we can improve that. It's like, how can we keep your skin in the best condition it is? How can we improve the health of your skin? So we use health rather than fitness, but maybe that's because I'm a doctor and we like to throw the health, the health word in. But it's very much a proactive approach to skin, and we're saying let's try and keep your skin in the best condition we can. And if we've got a very young patient, if we start talking about anti-aging, they're going to think, what are you trying to sell me? But if we're talking about how can we keep your skin in really good condition, well, then they're more receptive. And the other thing about these products is, if used appropriately, they're very well tolerated and can be used on all skin types. So they're also very versatile. So these products are in cleansers, toners, moisturisers, sunscreens. We've heard about a few different products today which contain these ingredients. So you really can plug it into different parts of your acne algorithm. And as we've said before, what makes a good topical acne treatment? Well, as we've said, effective and safe and well tolerated. So I'd like to finish up just with going through a small trial on NAG with respect to acne. So we've heard about some other benefits of it, but this was looking at its effect with acne. And it was a small trial, but it was basically comparing NAG with 10% benzoyl peroxide. So both groups were blinded and randomised, and they used the cream or gel that they were given twice a day for 8 weeks. And what we can see is both worked well. But what this graph shows is that the NAG actually worked better sooner, which is more likely to engage your patient and keep them using the product because they can see the improvement sooner. But as you can see at 8 weeks, there's a clear trend of improvement. Now, the benzoyl peroxide did work a little bit better than the NAG, so there's things you can take home from that. Maybe NAG for acne-prone skin, mild acne. If it's a little bit more severe, maybe that's when we add the benzoyl peroxide. But the benzoyl peroxide does come at the cost of increased irritation, so we just got to remember that as well. And then if we look at the non-inflammatory acne lesions, we can see both cause a good improvement as well. And here we can see just one subject from the trial. If you look at the forehead, you can see that there's a good improvement with the inflammatory lesions there, the closed comedones there, over an 8-week period. And not only the inflammatory lesions, but the tone and texture of the skin is improved. And this is early days, it's only 8 weeks. That's going to continue to improve with ongoing treatment. But the big difference, as I've alluded to before, is that the NAG was better tolerated. So the dark blue line is the NAG, and the pale blue line is the benzoyl peroxide. And we can see at every point with respect to burning or stinning or drying, the NAG performed better. And as I've said, if a product's stinning, irritating, the person's less likely to use it or continue to use it. And this is saying the same thing in a different way. I've put this up here just to remind us of our barrier function and the difference between acne and non-acne skin. But basically, the NAG was better tolerated at the start. And what's interesting is that dryness, stinning and peeling really only became an issue at about week 4 and week 8. So what's that telling us? It's probably telling us that after 4 weeks of putting something that's highly irritant on the skin, we're starting to get sensitive skin and getting stinning and also the dryness. So in conclusion, this study showed that the NAG, N-acetylglucosamine, worked well for inflammatory lesions and it was well tolerated by users. But in addition, we have all of these other benefits, which we've heard about already, but basically improving the thickness of the skin, elasticity, just the general appearance of the skin. So in summary, I've discussed the 4 factors which are responsible for acne, and also mentioned some other changes in acne-prone skin that you may not have been aware of. I've shown you that there's a vast array of acne treatments, and it all depends on your level of prescribing and intervention and the patient population that you might see with what you employ, but the need to recognise if things are not responding to treatment or if the acne is very severe and it needs onward referral. I've given you a brief overview of my approach to topical acne treatment, but it's very much an individual thing. So I'm assessing the patient and tailoring what I give the patient depending on their skin type and their concern. So we'll always keep that in mind. There's no one algorithm for every patient. And then also, we're learning more about this, the importance of adherence and tolerability. And I tell the teenage acne patients that, one of the main reasons the treatments don't work is because people don't use them. So if you're not using the treatment, it's not going to work. So we've got to find something that people are happy to put on their skin and they see the benefits from. And then also the importance of skin health and skin cosmesis. So we're looking beyond acne. Once we've cleared up the acne, we want to make the skin look good as well. And then finally, we touched on the role of AHAs, PHAs and NAGs, which I think we're probably going to hear more of over the weekend. So thank you for your attention.